Greetings and welcome to the MBMT Link webinar entitled Updates in the Prevention and Treatment of Chronic GVHD. At this time, all participants are in listen-only mode. A question and answer session will follow the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on your screen. As a reminder, this conference is being recorded. It's now my pleasure to turn the call over to your host, Jennifer Gillette, Staff Social Worker with MBMT Link. Please go ahead, Jennifer.
Thank you so much, Kevin, and thank you everyone for being here with us today. We are so glad you're here, and we're really excited about what we're going to be bringing to you in the next hour and a half on the updates and the prevention and treatment of chronic GVHD. Before we begin today's program, I just want to thank our sponsors, Sanofi and Johnson & Johnson. Here's a brief outline of how we are going to have our program today. We're going to have probably about 20 minutes from updates regarding chronic graft versus host disease from Dr. Corey Cutler, and then we'll have about another 20 minutes from psychosocial and emotional needs of chronic graft versus host disease patients from Daniel Gaylor. And then we're going to hear more about the patient experience from Judy Fine-Elstein, a survivor of acute myeloid leukemia. And then, of course, we'll have our question and answer period. Just in case anyone's not familiar with the National Bone Marrow Transplant Link, I just want to take a couple minutes to inform you. We are dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources, support, and education. We link you to experts across the country in all topics related to transplant, and to others who have made it through the journey before you. If you are interested in any additional services from us, I have our phone number up top, as well as the emails that you can reach either Peggy Burkhart or myself, Jennifer Gillette, and we're happy to assist you. Some of the resources we offer to people are, one, we have our Healing Arts program that's very popular, like virtual watercolor classes, journaling workshops that promote creative recovery. We have our Lunch and Learn programs monthly with virtual discussions featuring experts and survivors on transplant-related topics. We have our Marrow Masters podcasts, which cover chronic graft versus host disease, survivorship, new treatments, and those are available on Simplecast and YouTube, as well as where you listen to your podcasts. We have annual educational sessions and webinars addressing transplant challenges and new developments. We have a peer support program, which connects patients, caregivers, and survivors with trained peer volunteers. We have our Celebrating Second Birthdays program that honors transplant anniversaries with a special card and acknowledgement. We have our Survivors Thrive Book Club, which is a virtual book club focused on survival and healing. These are some of our great books. We have award-winning resources, and if you go to our website, some of those are free downloads, and some of those are ones you can order or call us, and we can send them to you as well. We have a very active Facebook page for daily inspiration and tips. This year, we've had approximately 750,000 views, and our podcasts have had about 39,000 downloads. So come see what you're missing. We have a lot of great resources for you if you're not familiar with that. Again, a thank you to our partners. We could not do the work we do without you, and so we always want to acknowledge your generosity. Just a little medical disclosure for today's program. The highlights are we are not giving you medical advice today. We are giving you information that can stimulate conversation with your doctor. So make sure that if you have anything that is something that stuck with you today, discuss it with your provider and see how it fits into your individual medical plan. And now I'm going to introduce you to the speakers we have here with us today. We truly have the dream team. Corey Cutler is here with us today. He's the director of the Stem Cell Transplantation Program at the Dana-Farber Cancer Institute and a professor of medicine at Harvard Medical School. Dr. Cutler graduated from McGill University Faculty of Medicine, completed a residency in internal medicine at McGill University Health Science Center, and completed fellowship training in hematology, medical oncology, and stem cell transplantation at the Dana-Farber Cancer Institute. Dr. Cutler earned an MPH degree at the Harvard School of Public Health. Dr. Cutler's research is the prevention and treatment of acute and chronic graft-versus-host disease. Dr. Cutler also studies the role and timing of transplantation for the myelodysplastic syndromes and is a contributing author on more than 300 peer-reviewed publications. Dr. Cutler is the immediate past president of the American Society for Transplantation and Cellular Therapy. And then we have with us Daniel Gaylor. Daniel is a licensed clinical social worker, a board-certified oncology social worker, and an advanced certified hospice and palliative care social worker. He's obtained his bachelor's degree in psychology from Florida State University and his master's in social work is from St. Leo University. He has worked at Moffitt Cancer Center for 7 years and currently serves as the BMT, CI, and hematology social work supervisor. Prior to joining the team at Moffitt, Daniel was a field social worker and social service manager for a local hospice agency where he oversaw the bereavement and social work teams. Daniel is also a professor at the clinical field liaison for St. Leo University's graduate social work program. And then Judy Fine-Edelstein, AML survivor. Judy was diagnosed with AML in 2020, and after 1 year of aggressive chemotherapy and subsequent relapse, she received a stem cell transplant in October of 21. She has experienced GVHD and other side effects from a chemotherapy and a stem cell transplant, but is continuing to adjust to the new normal. Judy has also been a neurologist in Massachusetts for 30 years and recently completed a master's in bioethics at Columbia University. Her unique perspective as both a physician and a patient has deeply informed her work as co-chair of Dana-Farber's Patient and Family Advisory Council, where she advocates for the vital role of mental health services in supporting patients from the moment of cancer diagnosis through survivorship. Thank you, everyone, for being here today, and now we'll hear from Dr. Cutler.
Well, great. Thank you very much, Jennifer, for introducing all of us, and thank you to you and Peggy for putting this program together today. I'm going to speak to you about updates in transplant and graft-versus-host disease. I'll probably take 20-25 minutes at most to go through some information on the topic. Before I begin, I will make that these are my disclosures, that I do some consulting work for some of the pharmaceutical companies, and in particular some of the companies that we'll be discussing products from today, since they're all in the graft-versus-host disease space. So first and foremost, and most importantly, is that we have now really turned a corner in transplantation with outcomes improving year over year over year. And this is a slide that's new, but it's from data back before 2020 because we need long-term data to generate curves like this. But the gist of this slide in the middle is that rates of graft versus host disease are going down, and right on top, rates of survival are simply going up, and there's no other way to sugarcoat this. There are many reasons why transplantation outcomes are improving. We've gotten better at prepping people for transplant. We've gotten better at preventing and treating graft versus host disease. And we've gotten better at preventing and treating relapse of malignancy after transplant. But today, I'm going to spend my time really talking about prevention of a little bit of acute, but mostly chronic graft versus host disease. So graft versus host disease prevention is an extraordinarily complicated space. The immune system has a myriad of pathways that can all lead to the same end point of inflammation and graft versus host disease. And so this slide is just meant to illustrate that our immune systems are actually complex, and there are many different ways that we think we can prevent the clinical scenario that we all call graft versus host disease. There are some very easy methods that our field has learned over time. Things like using bone marrow stem cells rather than peripheral blood stem cells. This is from a very seminal article where we literally randomly assigned patients to receive one or the other. Both the donors and recipients agreed to be part of this trial, and it was very clear that bone marrow transplants are associated with less graft versus host disease than peripheral blood stem cell transplants. So a very simple mechanism that we can use to prevent some of the morbidity of GVHD. But the star of the show in the last 10 years is something that we call post-transplantation cyclophosphamide, or PT-Cy for short. When you get a transplant, the donor's immune cells arrive with those stem cells, and some number of those immune cells, or T cells, immediately start to rev up and get ready to cause graft versus host disease. That actually is taken advantage of with this way of preventing GVHD. We wait until those cells have revved up, and then we give the recipient a dose of chemotherapy, cyclophosphamide. And that dose of chemotherapy preferentially kills cells that are revving up and that are about to start to cause GVHD, leaving behind immune cells that the body needs to fight infections and potentially to fight leukemia or lymphoma. So this has really become one of our dominant standards of care to prevent graft versus host disease, and it was based on this very large trial that the entire transplant community participated in, the Blood and Marrow Transplant Clinical Trials Network, or BMTCTN, is our nation's large clinical trial arm. It's where we do seminal studies. And I'm going to jump right to the punchline of the trial. The PT-Cy group, here shown in black, had superior outcomes at 1 year related to what we called the primary endpoint, which was freedom of graft versus host disease, relapse, and being alive at that 1 year mark. And to us, this very marked, dramatic improvement you can see at the end of the curve really was a game changer, and almost overnight became the standard of care, at least in reduced intensity settings. The reason why that happened is because even though there was this great improvement in graft versus host disease outcomes, there was no decrement in relapse. So we've always been worried that if we suppress the immune system and prevent GVHD very effectively, we're going to see more leukemia coming back after transplant. And in this trial, in fact, we did not see that at all. So it's the standard of care in reduced intensity transplantation in anyone who's getting a half-matched or very mismatched donor transplant, but it's not quite the standard in all transplants. So the myeloablative space, there's still some room. But as a field, we have multiple trials that are actually now happening that are going to try to improve upon this PT-Cy platform. One of the ways we're doing that is by harnessing the power of the immune system itself. So we all have multiple different types of immune cells that are in circulation, and one very small fraction are called regulatory T cells. These are T cells that are the brakes of the immune system. They are there to stop or halt immune reactions. And in fact, the Nobel Prize in Medicine was given this year to 3 scientists who made fundamental discoveries about the role of these immune cells in our circulation. And we've harnessed this for one up-and-coming method of trying to prevent graft versus host disease. In a conventional transplant, we just give all the T cells that come out of the donor. But this new technology being put forward by a company called OrcaBio separates out the T cells into their various constituent subtypes, and we give all of the regulatory cells and then just give a small fixed number of the more inflammatory type regular cells. So you set up a tolerant environment in the bone marrow, and then you give your transplant. This is not yet FDA approved, but there are trials out there, and here's one of them that has demonstrated, in comparison to standard GVHD prevention regimens, shown in yellow, the OrcaBio product works better than standard of care. Now, this is not PT-Psy in this transplant trial, but this is proof of principle that this process or this strategy is probably beneficial in transplantation. So here are some other outcomes from the trial. These are, this is now rates of GVHD-free survival, etc. So let's jump right into acute graft versus host disease. So here, we know that we have to give steroids when it does occur. Steroids are not great. Lots of people require second and third line therapy for acute graft versus host disease, and we're not great at that yet. However, we now have some alternative strategies. So for a small subset of people with acute graft versus host disease, we can actually avoid steroids entirely. And this is the results of a trial where we randomly assigned individuals with lower risk of bad outcomes from GVHD to either receive steroids or to receive a drug called sirolimus. On the far right side, we see that the survival was not impacted. On the far left side, we see that doses of prednisone were obviously far lower in the sirolimus group. Some individuals eventually needed it. But this is one of many strategies we're coming up with to try to avoid steroids entirely in the acute GVHD setting. Now, for patients who need to move on beyond steroids and get other agents to treat their GVHD, we now have one FDA-approved compound for the treatment of steroid-resistant or steroid-refractory acute graft versus host disease. And you can see on the left-hand side, this agent ruxolitinib was about twice as good as what we considered as a control in this study at treating individuals with acute graft versus host disease that was not responsive to steroids. So this is great. We're doubling response rates, but you'll notice that the top of the ruxolitinib bar ends around the 60 to 65% level. So clearly this is not good enough for everybody. And so we're now doing trials where we're adding on agents to ruxolitinib. This is just an example of a trial design called the Stargaze study. My colleagues have gotten very creative in naming their trials. And this is a trial looking at the addition of a drug that is designed to stimulate the recovery of the gastrointestinal tract to actually regrow functional GI cells. And our early data from this two-pronged approach suggests that the combination of these two drugs is actually pretty good and looks like it has a pretty high response rate in a group of patients who have poor risk for bad outcomes with acute graft versus host disease. So lots of activity in the steroid refractory acute GVHD space. But we're really here to talk about chronic graft versus host disease. So I'm going to spend my last 10 minutes talking about what we've done in chronic GVHD. I'm particularly proud of these next few slides because it details the FDA approval of now 4 drugs in the management of steroid-resistant chronic graft-versus-host disease. The first was a drug called ibrutinib, which works on the B-cell arm of the immune system, so a slightly different approach to the management of GVHD than attacking T cells. This drug was approved in 2017, so it's now 8 years on that we've had access to this compound. And of the 4 drugs that we have, it's probably the least effective and is therefore used the least. Now, next up is a drug called belumosudil, which was approved back in 2021. This was the first drug ever developed specifically for the management of chronic graft-versus-host disease. It works by targeting an entirely new and previously unrecognized molecular pathway by targeting a molecule called ROCK2. And so this is a ROCK inhibitor, and our colleagues got very creative in naming the trials here. So we've had the Rockstar trial and the Rock and Roll trial, and I'm currently running one called the Bebop trial, etc. So this is another great option for our patients with steroid-refractory chronic graft-versus-host disease. Going over the results from that trial, we're now seeing that 3/4 of our patients who are treated with this compound in a formal clinical trial setting are actually responding to this compound. The duration of response is tremendous. So now we're looking at 18+ months on average. If you look on the right side, 77 weeks, so 18 months. That's the average time that patients respond to this compound. And very importantly, the time to next therapy is now beyond 2 years, with many patients, and you can see that in the middle bars where we haven't reached our medians, many patients never requiring another compound after a couple of years of therapy with this drug. So we're very pleased with how this is working. Now, our colleagues in the pharmaceutical industry have learned that if they can make one drug, they can probably make a better version of that drug and use it to treat people out of the gate. And so we already have second-generation ROCK inhibitors that are entering the space, and we're going to see a lot more about these second-generation compounds in the coming years. So ruxolitinib will make a repeat performance here. This is the drug that I talked about for acute graft-versus-host disease. It works by blocking inflammatory pathways in our immune cells. And after it garnered an approval in acute graft-versus-host disease, it has now garnered an approval in chronic GVHD as well. And it is, in fact, the single most used drug for the therapy of GVHD that we have. Ruxolitinib works pretty darn well. So you can see on the far left that 76% response rate, just the same number, if you will, as the belumosudil against a best available therapy, or BAT, on the left-hand side. With that, we see a very marked prolongation of what we call failure-free survival. And so this means being alive and well without needing a new GVHD drug. That's what the failure refers to, having failed the ruxolitinib. So a marked advantage over best available therapy, where most patients eventually progress and need another compound. So I've talked to you about a ROCK inhibitor. Ruxolitinib is a JAK inhibitor. The pharmaceutical companies have now learned that they can try to get one compound that actually blocks both pathways. This is a bit of a chemical engineering marvel, but there is a new compound called rovadicitinib, which blocks both. And that drug will be in-licensed in the United States very shortly, I'm sure, and will make its way to clinical trials here. And then finally, we have a compound called axatilimab, which was approved by the FDA in November of 2024 and made it to the shelves by March or so of 2025, and is now the fourth drug in our toolkit against chronic graft-versus-host disease. This was presented at the largest hematology meeting in the world, called the American Society of Hematology. About 30,000 people witnessed this presentation. This was abstract number 1 at the conference, and it demonstrated on the far left-hand side in the dose that we currently use that magic 3/4 of patients will actually respond to the compound. And so this 75% response rate put it in the same class as ruxolitinib and belumosudil, and that's how it got its FDA approval. And so here's the primary publication, and it looks like it was August, not November, my apologies, that it was approved by the Food and Drug Administration. So, not to be outdone in this space, there are now 2 follow-on compounds already for axatilimab. Axatilimab is given intravenously, and there are 2 compounds that can be given orally that target the same pathway. They're called pimicotinib and vimseltinib, and vimseltinib is already on the market as a therapeutic for a very rare form of sarcoma that has the same pathway overexpressed. And so you'll hear more about these compounds in the coming years as their clinical trials finish. So that's a very brief overview of what we're doing in both acute and chronic graft-versus-host disease. I'm going to end by stressing that GVHD care is improving dramatically, both on the prevention side as well as the therapeutic side. For acute GVHD, we have a better appreciation of the toxicities of therapy, and that's why we're trying to move away from corticosteroids. And in chronic GVHD, far better methods of prevention, 4 drugs that are approved, multiple drugs in development. And I think the future really is looking quite good in the acute and chronic GVHD space. And with that, I think I am going to end my presentation and pass you off to Daniel.
Thank you very much, Dr. Cutler. That was some great information. So as we begin today, I again want to thank you all for being here. I appreciate the opportunity to be presenting today. I'm going to be talking about building our tool belt. So what's in your tool belt? Emotional and psychosocial issues related to GVHD. I'm going to do my best to keep this to 20 minutes. I've given this presentation similarly at times in the past, and it's been a little lengthier at times, so I'm going to do my best to condense it, but to keep you engaged at the same time. So our brief agenda, discussing the emotional complexity of navigating GVHD, and then working to understand how we can build our tool belt. And we'll talk about what that means as we progress through our conversation today. But building our tool belt is an analogy that I have used with my patients and with my teams throughout the years, and it's something that I think is very applicable in this setting. So we're gonna talk a little bit about that. So GVHD, graft-versus-host disease. You can see all of my emojis here. I think this picture is extremely applicable when we start talking about this. As patients begin to meet with their doctors and their providers, you begin to absorb all the information that comes with graft-versus-host disease. You're beginning to think about your transplant, or you're in recovery, you're in survivorship. All these different thoughts, right? All these different emotions, concerns, feelings that start to come with the idea of graft-versus-host disease. and how to navigate that, right? The various ups and downs. So all these different emojis, right, to capture the various different things that we're beginning to experience, these emotions, right, that come with this. Very complex, lots of different things that we can be experiencing here as we start to navigate everything that comes with GVHD. So in reality, right, some of those emojis are maybe not the most applicable, but what are we really starting to think about when we start to navigate this? Feelings of uncertainty, fear of the unknown, anxiety, sadness. Maybe we're thinking about trading problems. I've heard this a lot from my patients. Thinking about, yes, maybe some of our disease is taken care of, but, now we have a multitude of other issues when we're talking about GVHD. Maybe we're angry. Maybe we're hopeful, right? Maybe we're hoping that, okay, maybe this isn't going to be so bad. Maybe I'm going to be able to manage this, right? Maybe we feel optimistic. So you can see here, again, just a wide variety of things that we're beginning to experience when it comes to the psychosocial, factors of this, right? The emotional needs of this. It really varies. There are ups, there are downs, there are a lot of different things that we can begin to experience as we start to toggle through this. Some can be on the positive side, some can be on the more negative side, but there's a lot to unpack and there's a lot to wrestle with this when we begin to process all this information here. So relief and anxiety, right? Also recognizing that our emotions can cycle as we process information. So there's the ups, there's the downs. Unfortunately, that does come with GVHD, right? And it's important to recognize that up front. So I really want to validate that and normalize that for everybody. The normalcy of the ups and the downs. There will be the good days. There will also sometimes be the not so good days, right? Sometimes those bad days. All of that, unfortunately, does come with the territory. But it's important to recognize that so that we can learn to expect it, learn from it, and how to prepare for it. So again, the relief and the anxiety, we're going to experience both. And as we're beginning to process all the information, it's important that we can then begin to say, okay, how do we prepare for it moving forward? So all these different emotional reactions that we are experiencing, completely normal, right? That roller coaster, you've probably heard this term from various people, throughout your life, the emotional roller coaster that we are on, completely normal, right? There is no right or wrong way to be processing all of this different stuff that we're all going through, right? There's no template, there's no layout, there's no handbook, right? There is no right or wrong way to process all this. So if you're having those feelings of anger, if you're having those feelings of sadness, if you're feeling irritable, whatever it might be, it's important to recognize that it's okay to be feeling that way, right? You have a right to feel that way. It's very normal. It comes with the territory is the phrase that I use. GVHD is complex. It's incredibly complex. No one patient's GVHD is exactly the same to another patient's, right? It's incredibly unique to that one individual. Very important to recognize that and to be able to say, okay, this is my journey, and be able to recognize and say, I'm going to work with my medical teams, I'm going to work with my support system to manage this. But incredibly normal to feel any of those different things as you start to cycle through this. The practical and emotional aspects of it, right? So life after transplant, what does that look like? The follow-up care, maybe navigating insurance issues, maybe considering employment to work, and physical changes that we know can come with the GVHD. And the emotional issues, managing our emotions, right? How do we respond when we're feeling angry? How do we respond when we're feeling sad? How do we respond when we're really worried about things, right? What does our day-to-day life look like when we're feeling all of these different things? What is our, quote, new normal? It's a phrase that I don't like to use too terribly often, but unfortunately it is a phrase that I think is very applicable for almost everybody, right? Things change, and that's okay. It is the only constant in life is change. So as we start to navigate the practical things moving forward for ourselves, and as we start to navigate the emotional changes for us as well, how do we respond to these things, right? What does it look like for us? Because again, no GVHD is the same for everybody. The severity of it can vary, the frequency of it can vary, how it hits us can really be different. So it's important that we're staying in touch with our providers, and it's important that we're staying informed and leaning on the resources and supports that we have to stand and to be in tune to say, okay, this is what I'm experiencing, this is what I have, and this is what I can do about it moving forward. The best thing that we can do, in my opinion, is to be able to recognize and say, this is what I have, this is what I'm experiencing, and now I can act on it. Sometimes the worst part is not understanding what we're experiencing, because when we don't understand it, we feel out of control. Feeling out of control is one of the worst things that we can ever go through. But when we do understand something, we can act on it. We can put a plan in place, and then when we have a plan in place, we start to feel like we've gained a little bit of control over something that otherwise we felt out of control. Then we start to feel a little better. Anxiety starts to decrease. Stress starts to decrease. So it's having that recognition and that ability to say, I understand what I'm feeling, I recognize this in myself, and I know what to do with it moving forward. Some of the best things that we can do are those things, to say, I know what this is, and I know what I can do with it moving forward. That's how we can work to lower some of those difficult emotions that we're experiencing in life. So life is never really the same, right? I've often had many patients tell me throughout their time in transplant that the transplant is their new birthday, right? That day zero that we talk about in the world of stem cell transplants, that's their new birthday. So it is adjusting to the new normal. It is about being open to and accepting of changes. It's working to increase that connectedness and decreasing the isolation. So yes, we know that GVHD can cause some of these negative emotions and these negative symptoms, but it's building that awareness and it's building that insight to be able to say, I know what this is, I know what to do with it when it comes up, right? I'm starting to build my tool belt, adjust to the new normal, be open to and accepting of these changes that we know we're going to have to experience, and then in turn, work to increase our connectedness, decrease the isolation that we know can be a barrier. When we withdraw, when we pull away, it can cause those negative symptoms to increase and make it harder for ourselves. So these are really the goals, right? Work to adjust to the norm, be open to changes, increase the connectedness, decrease the isolation. The strain of worry. So these are some of the things that we want to look out for, these symptoms of depression. Loss of interest in previously enjoyed activities, feelings of hopelessness, helplessness, worthlessness, those feelings of being overwhelmed, difficulty making decisions, inability to concentrate. Maybe we're having a hard time eating or sleeping. Maybe we're sleeping too much or not enough, eating too much, not eating enough. And when we look at the other side here, when it comes to anxiety, maybe we're just having general feelings of dread, we're hypervigilant, we're irritable, we can't concentrate, right? Again, issues with sleep, panic attacks. So yes, we understand and we've learned a lot about the medical side of the GVHD, but how that impacts our emotions, here's where we can see it, right? Constantly being worried about these physical symptoms that we're experiencing. How is this making us feel emotionally? Being on the lookout for some of these symptoms, starting to feel angry, starting to feel irritable. Are these symptoms starting to persist in us and becoming more chronic, more long-lasting? These are the things that we need to be on guard about. They can become problematic if we aren't aware of them. They can become difficult for us if we aren't plugged in and recognizing them when they start to pop up. If we're plugged in and we're aware, we can do something about them, right? Again, we can be in control, we can put a plan in place, and that's when we can start to take back some of that control, and we can feel like we are really in charge of this. So it's important to look out for some of those symptoms. Again, life is never really the same, but the same is true every other day of our lives. That's perfectly okay. And the only constant in life is change, no matter the circumstances, transplant or no transplant, GVHD or no GVHD. These are rules of life for everybody. Things are constantly changing all around us all the time. Are we aware of it or not? Maybe that's the question we should be asking ourselves. But again, it's okay that these things are changing. It's a matter of staying plugged in. It's a matter of understanding what's going on around us, because when we understand, we can do something about it when things change. So, motivation. This is a phrase I've used with many patients. If you think you can, you're probably right. If you think you can't, you're also probably right. So, identify your sources of motivation early on. GVHD can really kick our butts sometimes emotionally, right? Let's be honest. Let's talk about that. It's hard. It can be really difficult. So when those bad days creep in, when those hard times kick in, what pulls us through those difficult days? What are the things that we can lean on to really help us get through those tough times? Identify those sources of motivation early on. Write them down. Look at them daily. Set aside time to focus on each day. I'm a big fan of having something tangible, having something physical that you can touch, which is why I like writing things down. Because when we're having a bad day, when we're feeling crummy, when we're feeling kind of down, it can be hard to think clearly. And it can be hard to lean in and say, okay, what were my motivators again? You know, what are the things that make me happy again? When we're in a bad mood, we're in a bad mood. And sometimes we just want to be left alone. But it's easier to say, where's that piece of paper, right? Where's that list I had? Where's that thing that I can touch, that I can feel, that I can read? Sometimes it's easy to just go to that thing and we don't have to think. We can just go to it, touch it, look at it, read it. So I'm a big proponent of that. Communicate. Bad communication makes bad days worse. Good communication can improve that in a lot of ways. Our loved ones and our friends aren't mind readers, so we got to be able to communicate and let them know what's going on. It's never what we say, but it's always how we say it. Advocate for yourself, right? So it's, again, working to decrease the isolation, increase the connectedness. Working towards that new perspective and that new hope. GVHD does not have to be the thing that defines us, right? There's a big difference between saying, I am a cancer patient versus I am a patient who has a cancer diagnosis. I'm a GVHD patient. I am a patient who has GVHD. I am a person who's managing GVHD, not letting the thing define us, not letting the cancer diagnosis define us. We're not leading with that. We're not leading with GVHD. It does not have to be the thing that defines us. There are so many other good qualities and factors about everyone. Those are the things that define us. So find that support. Hold on to those things. Seek out assistance. Consider individual counseling if you need to. Seek out the peer support. There's a lot of programs out there that do that. Maybe some support groups. Try new coping strategies. One of my favorite phrases, expressions, emotion seeks expression, right? I use the analogy of, think about you've seen this in movies and TV shows, you're boiling a pot of hot water to make tea or coffee or something like that. And when the water gets hot enough, the tea kettle just starts yelling and screaming, right? It's making all that noise because the water is hot enough. We are those tea kettles. And when stress and anxiety and frustration and anger and all these difficult things build up inside of us, eventually we're going to yell too. We can only take so much. The pressure builds up. The pressure builds up in the tea kettle, it screams. Pressure builds up inside of us, eventually we're going to scream too. So emotion seeks expression. When we're having difficult days, we got to be able to find a way to let some of those difficult emotions out as well. GVHD can be difficult. It can cause some frustration in us, but there are a lot of different things that we can do to combat it. So tools, building our tool belt, going back to that analogy that I referenced. I like to think that in life, we all wear tool belts every day, but they're invisible. So in reality, construction workers, contractors, people in that line of work, they wear tool belts. They actually wear tool belts, real ones, because they need different tools for the different projects that they're working on. They have wrenches and they have hammers and they have screwdrivers and things like that. So as they encounter problems and projects, they have tools that they can use for those projects. So I like to think that as humans, we all wear tool belts every day. They're just invisible and you can't see them. I'm wearing mine right now and all of you are wearing yours. So our goal throughout life is we are constantly adding to our tool belt. So as we journey through life and we encounter problems and projects and things like that, we have different tools that we can use to overcome those problems, and we have different tools that we can use on those projects, right? GVHD is just a project. It's just another barrier that we have. It's a problem that we need to fix. So we're going to add tools to our tool belt. So what are the different tools that we have? Communicating with our medical team, maybe considering deep breathing exercises, meditation, mindfulness, counseling, exercise, expressive activities, spiritual practices, our important relationships. It's all a matter of finding what works for us and adding these tools to our tool belt. So throughout life, I think that's one of our biggest goals, adding tools to our tool belt. GVHD, yes, it can be a problem, but there are a lot of tools out there to combat it. So we learned about some of them earlier, and now we're going to learn about more of them, and all of you can continue to add tools to your tool belt. One day at a time, right? Transplant GVHD is a marathon. It's not a sprint. So we're taking things as they come, one day at a time, knowing that, yes, we are capable of overcoming these difficult emotions. We're capable of overcoming this stress, the anxiety, the uncertainty that unfortunately can come with GVHD. One day at a time, with the help and support of your medical team, your doctors, your loved ones, your system, we can overcome it. So with that, I will pass it on to our next presenter, and I thank you all for allowing me the opportunity to be here today.
Thank you so much for including me in this most informative webinar, and thank you for allowing me to share my story. I'm going to go back to March 2020, and I have to say life was good. I'm married. I have 2 grown children. I was working as a neurologist. I had been made chief of neurology at my hospital. I was teaching medical students and residents, and things were good. Often in my life, when things are tough and I look for something that moves me, I turn to Shakespeare. And I will say, when sorrows come, they come not single spies, but in battalions. In other words, when it rains, it pours. Because we all know that in March 2020, we were hit by the pandemic. And for all of you and for me, things were very tough. I started to experience a lot of fatigue, but I was under significant stress. And so initially I ignored my symptoms. But I had this chronic cough. Despite steroids, despite medications, I felt pretty awful. I also developed shortness of breath when I would take my dog for a walk outside, and I noticed a few bruises. And when I think back now, I don't know how I missed it, but something was very wrong. I eventually saw a colleague of my husband's, as most doctors' offices were closed then. He drew some blood work on May 19th, 2020. I went back to work that afternoon until I received a call from an oncology colleague of my husband's who told me to go right to the emergency room, that my blood work was very abnormal. In the emergency room, of course, a lot of diagnostic tests were done. Doctors weren't even coming into the hospital, and I received a call on the phone from one of the hematology fellows telling me I had AML. Now, when I went to medical school and graduated in 1988, AML was, for the most part, a very, very difficult disorder with a very poor prognosis, and I thought I would never make it out of the hospital. I was admitted then to Dana-Farber, the Brigham Women's Hospital. My first oncologist, who's a wonderful human being, did a bone marrow biopsy, and I was lucky because I had in quote, I put favorable set of mutations, what's called inversion 16, and the plan was that I would not need to go directly to transplant, but I possibly could be in a long-term remission with chemotherapy. The plan was for induction chemotherapy with the famous 7+3, and then cycles of consolidation chemotherapy over the next number of months. Over that first year, I had many hospital admissions, including for the induction chemotherapy for about 5 weeks, weeks of hospitalization, as many of you probably experienced with infections, colitis, pulmonary infections, and I developed very significant relapse anxiety. Despite being in remission and my team feeling that I was doing well, I couldn't sleep and I had a lot of difficulty. I had my bone marrow biopsy at 1 year, and I had negative measurable residual disease. And I planned to go back to work virtually in June 2021 when I noticed some bruising. Laboratory work showed that I had blasts, a bone marrow biopsy. The plan at that point I knew was I needed a transplant. I spent much of the summer of 2021 in the hospital for salvage chemotherapy. It was really difficult. I had multiple infections, terrible mucositis, so I was treated with IV nutrition and IV narcotics. And I will share with you the lowest moment when I fell in the bathroom, hit my head, and sustained a skull fracture. I looked like I emerged from a prize fight. I had terrible refractory nausea, insomnia, and tremendous anxiety. In October of 2021, 4 years ago, I received my transplant from a very well-matched donor, who, by the way, I speak with on Zoom every month. I had a long admission then. Again, I think I spent most of it in bed, not even being able to get up to the chair. I had acute graft-versus-host disease of the skin. I remember my arms, my legs, my chest, my back turning a dark color, peeling, burning. I was treated with steroids for that, and I also developed acute GVHD of my gastrointestinal tract. I had terrible diarrhea. I had terrible abdominal pain. And then I went home. I remember the first 100 days barely being able to walk up and down the stairs. Previously, I was a very active person. I could barely eat. I had vomiting, diarrhea. My skin was in terrible shape. I saw a dermatologist. I was treated with steroids. I had continued abdominal pain. I felt like I couldn't read a book because of dry eye and pain in my eyes, sores in my mouth, diffuse joint pain, and the fatigue, which I still experienced to a great degree at that point, was overwhelming. Over the next 6 months, I had a colonoscopy. The biopsy showed that I had some chronic GVHD. I was very lucky. Dr. Cutler described cyclophosphamide being a treatment that right now still is not necessarily standard of care for patients like me, but my oncologist and I discussed the option, and I did receive cyclophosphamide after my transplant on days 3 and 4. I feel like that may have made a big difference for me. So I was treated with oral steroids, but they did not really help my gastrointestinal symptoms, and over time they improved to a great degree. I still had significant sores in my mouth, fatigue, and joint pain. I was able to walk and do more activity, but I had very low blood pressure, palpitations, and saw a cardiologist for a period of time. My husband and I for a long time, lived in a bubble. Treatment ended, and for me, that was the really hard part. I will say, and I want to share with you all, that even though I'm a physician, even though it may seem like I have things together on the surface, I really was a mess, and I still have very significant anxiety. I developed bad dreams worries, and a lot of avoidant behaviors that I still have. For example, driving in certain directions makes me so anxious that I will relapse. And of course, driving has nothing to do with relapse. Many of the fears that we have may not be completely rational, but can be overwhelming. I've had ongoing therapy at Dana-Farber every other week. I also see a cognitive behavioral therapist, which has been helpful, and I see a psychiatrist every few months, and I am taking medications for my anxiety, insomnia, and PTSD. I've done a lot of integrative therapies. I do art therapy every month and meditation. My mental health is very, very important to me. In the next phase of my recovery, I adopted a dog who you just heard barking. I asked my oncologist, and he said, Judy, it will be the best thing for you. So we rescued Oliver. When I realized I couldn't return to my beloved career, I enrolled in a virtual cohort at Columbia University in bioethics. And about a year and a half ago, my kids and I went to an outdoor concert, which I felt comfortable going to, and we saw the Rolling Stones, and they were amazing. I started taking my classes, walking, and moving out in the world. It was almost 2 years before I invited anyone into my home to have dinner or spend time indoors. It was very important to me to give back to Dana-Farber, and I was named the co-chair of the Patient and Family Advisory Council. I will tell you that it is a new normal, as Daniel said, as I have tremendous fatigue. I have a neuropathy, and as a neurologist, it's frustrating. I have awful leg cramps, sores in my mouth, and my gastrointestinal system is not the system it used to be. I graduated in May, though, with my master's in bioethics, and they asked me to be faculty, and I'll be teaching neuroethics this winter at Columbia. I have good days and bad days, and there are days when my anxiety is pretty overwhelming. This summer, we did go hiking in Colorado, and my son and his wife are having a baby in January, and my husband and I will be grandparents. And I think my daughter is going to be proposed to very soon, so we'll have a wedding to plan. I lived under the illusion that I had control, and I thought that I would never get sick. My mother, as you see in the picture, is 99, and she's an amazing person. And I somehow just thought that I would go through life without a medical issue or a problem. Learning to live with uncertainty is very tough. I owe my life to Dana-Farber, my physicians, and the whole team. This summer, I am a very amateur cellist, but I even played with the Lexington Symphony in a program that made me feel very alive. I thank my family and Dana-Farber, and thank you so much for allowing me to tell my story. And I really want to say it's a tough road, but there's a lot of help. And I'm always happy if anyone reaches out. I'm happy to talk, share my story, or help be a support system for you. Thanks so much.
Thank you so much, Judy, and thank you so much to our other speakers as well. This is the part of the program where you get to ask your questions now. So, Kevin, can you please remind everyone how they can ask questions on this webinar?
Certainly. If you'd like to ask a question at this time, please type your question into the Ask a Question feature located on your screen. One moment, please, while we poll for questions.
And I'll just start since we do have one question. And Dr. Cutler, I believe this one will be for you. Is it possible that skin issues are the results of GVHD several years after umbilical cord bone marrow transplant for a patient 65 with a diagnosis of AML with a FLT3 mutation?
So that's a good question. Lots of factors to take into consideration there. How long after transplant? What are the skin manifestations? Because chronic GVHD of the skin can look like a number of other conditions. So I don't know that I can answer that question directly. I think the answer is anything is possible post-transplant, and I would recommend showing your rash or whatever is going on the skin to your transplant provider.
Thank you so much. I know we're waiting for others to ask their questions, and I will keep an eye on those questions as they come in. But I have another one for you, too. Dr. Cutler, I know you have just been so pivotal in the research and in your involvement with clinical trials and treating GVHD. For those out there that might be a little leery about clinical trials, what would you tell them?
Well, I think first and foremost, clinical trials are the way the field moves forward. And so you have to think about the trial in two ways. One is, will this benefit me? And I think that's really the far more dominant way to think about a clinical trial, because the second question is, will this trial benefit others? And so the answer to the second question is always yes, but it's not a reason to participate. Altruism is great, but it shouldn't be the reason why people participate. You have to be comfortable with the clinical trial, the question that's being asked, the way it's being answered, how the trial is designed in terms of what the alternatives are. Some trials can be as simple as having an extra vial of blood drawn with every clinic visit, or filling out a quality of life questionnaire. It can be as simple as that, and as complicated as testing out a novel compound that might not have been used in many other people before, and everything in between. So talk to your transplant physician if they're offering you a trial. Try to understand the risks and the potential benefits for you, and then decide if it's the right thing for you. And there always is a way to talk to somebody if you have further questions about clinical trials.
Thank you so much. And as we wait for any additional questions, I am going to ask Judy a question. Judy, regarding fatigue, I have simply been blown away at all that you have done post-transplant. You certainly, one, we appreciate your authenticity and sharing your story, but can you tell us how you manage fatigue and how you keep developing your strength to do all the things that you do?
Oh, that's very nice of you. I'm not all that sure that I necessarily manage it that well, but what I would say is I love to walk, and there's, I think back when I was, practicing clinical neurology, and with many neurological disorders, patients have fatigue. And I try to do some of those things. So, for example, obviously makes sense, do the best you can to get a good night's sleep. Sometimes I sleep very well. Sometimes it's a bit rocky. Exercise, although it sounds like, gee, I've exercised, I'm very tired, exercise really has been shown to help with levels of fatigue. And I love to walk. I love to walk my dog. I love to be active. I love to be outside. I have to constantly talk to myself. And with regard to the new normal and fatigue, I am busy, but I am a very early riser, and it's taken me a long time to realize that it's okay if I'm productive and active in the morning, but by 12 or 1, I'm absolutely exhausted and have to lay down on the couch. And I feel free to, if I'm visiting others, to also sit, lie down on the couch, close my eyes, rest. I think self-compassion and being kind to yourself are just as important as things like exercise, eating a healthy diet, trying to get a good night's sleep. So, and the other thing I would just say is talk to your doctor. For some people, there sometimes are medications that can help with wakefulness. So I'm trying to work on all of those things.
Thank you so much, Judy. I'm going to read some of the questions that I see coming in here and comments. One writer puts, my sister was a nun, and she said, if you hope, you cope. If you don't, mope. And this person thanks all of you for being here on this webinar today. And then there's one that has a question that I believe will be for you, Dr. Cutler. If you've been on a medication you couldn't tolerate 5 years ago, and I don't want to botch this one, but I will say Belumosudil, is there any chance you might tolerate it later? I had a stem cell transplant 11 years ago and have had many GVHD problems. Your thoughts, Dr. Cutler?
It's a good question. There's a very reasonable chance that you might be able to tolerate the drug better after a long hiatus like this, 5 years. Obviously, it depends on what type of reaction you had 5 years ago and whether it's safe or even wise to even consider trying it again. I will add that one has to be very careful in differentiating active chronic graft versus host disease from the long-term consequences of having had graft versus host disease. And I'll give you an example. So oral GVHD of the mouth is very well understood, and there's generally inflammation and ulcers and sores in the mouth. And as part of GVHD of the mouth, the salivary glands get attacked and are sometimes actually totally scarred down and destroyed. Now, you can treat oral GVHD with pills or rinses in the mouth, and you can actually make the active inflammation go away. However, if you have permanently destroyed your salivary glands, you will have a dry mouth forever because you're not going to regrow those salivary glands. So you have to make sure in a case like this that you're not going to try Belumosudil for a dry mouth that is likely irreversible. You want to make sure that you're actually going to consider using a drug again because you have active GVHD. And you can make the same analogous comparison for the eyes or for sclerosis of the skin. So I would just caution you that at 11 years, I suspect you don't have active GVHD, but I couldn't say that.
Thank you for that, Doctor. We also have just a fan club comment here. Dr. Cutler is my oncologist. It was great to see the mindset behind my treatment and infusion. Thank you for everything. Then another question for you, Dr. Cutler. Any new biomarkers for GVHD or response to therapies?
So we have biomarkers on the acute GVHD side that can predict the onset of GVHD and can predict outcomes to some degree. They are moderately useful in that they don't predict responsiveness or likelihood of long-term outcomes, in my opinion. On the chronic GVHD side, we unfortunately have nothing that is ready for prime time, but we have lots of my colleagues working on this, and hopefully in a year or 2 or 3, we'll have some more information.
Thank you. And another one for you, Doctor. Do chronic graft versus host disease, does it worsen over time? I'm 1.5 years out and have some oral issues, but I don't oral rinse at this time. Thoughts?
Well, it depends on how well you're actually treating the GVHD to let you know if it's going to worsen over time. But certainly it can, in fact, get worse if it's not treated fully or to completion. And so I think sometimes seeking expertise from an oral medicine physician, not a dentist, but a physician who specializes in oral medicine, might be the way to go. If you don't have access to an oral medicine physician, then a dentist is a good resource to use as well.
Great. And what about photopheresis? Is it possible to lose efficacy over time? How do you evaluate response to that therapy?
I think of ECP like any other drug. We have to use standardized response assessments to see if it's working or not. So measuring flexibility, looking at the skin completely, things like that. Does it lose efficacy over time? It certainly can. Just like some patients will lose efficacy from a drug, I think we would say the same thing about ECP and its potential to work forever.
Okay. Another writer asks, I've been on Jakafi for 8 months and understand it takes quite some time to taper off the drug. Why is that? And do the other drugs you mentioned have a longer taper? Additionally, Jakafi has had many side effects. Do the others have as many side effects?
So Jakafi is really a great drug overall. All the drugs have side effects. There's no such thing as a free lunch, unfortunately, here. And so you have to weigh the benefits and risks of each drug and how the side effects might affect you. One thing we do not know very well is how to taper off these drugs. Most of us do it based on our own intuition, but we don't have defined pathways. So everybody's physician does this a little bit differently. And I would encourage you to talk to your physician to see if there's a reason why they want you on this drug. And maybe it's really, maybe you should not be tapering off. But again, I couldn't tell you.
Okay. Thank you, doctor. And another one for you. My 13-year-old had a stem cell transplant in May 2024 for his high-risk AML, NUP98, and FLT3 TKD. To date, he had some minor upper GI GVHD. Is there anything you're seeing in patients that indicates whether or not a child will be able to avoid chronic graft versus host disease?
Traditionally, acute GVHD was considered the most important risk factor for chronic GVHD, but children have the lowest rates of GVHD have lower rates than GVHD when compared to adults. So certainly having some upper GI GVHD does not predict that your child will or won't have chronic graft versus host disease. There are many other factors that go into that, things like match status and how GVHD was prevented. So impossible to say, unfortunately.
Okay, thank you. Another one, lots of medical questions here, Dr. Cutler. Thank you so much. Another person writes, I had a bone marrow transplant 9/23 for MDS. I have leg tightness, but I've been reluctant to go on a GVHD medicine like Jakafi, which was just mentioned about 3 months ago as a possible for treatment. I'm reluctant to go on any medicine like that at this point, as I feel that tightness is annoying but livable. Would getting on something like this at this point be of value in your opinion?
Well, it certainly could be of value. A lot depends, again, on to what degree of tightness your legs are affected and how it affects your daily life. It's probably not too late, and with long-term therapy, these changes could actually be reversed. So again, it's a question for you and your physician, and without examining your legs, I couldn't give you personal advice here.
Thank you. Another one, Dr. Cutler, I started to develop frequent migraine headaches 3 years after transplant, and I read that they can be a result of heavy use of steroids after transplant. Have you seen this in your practice?
Well, steroids are associated with lots of side effects. Headaches and migraines certainly can be one of them. But again, without knowing your entire list of medicines and all the other investigations that you've had done for headache, really a question I can't answer.
Okay. This one is a very generic question. I know you could probably do several webinars on this one alone. Thoughts on GVHD of the lungs? Any recommendations for someone who might be trying to research more information about that, or just thoughts in general you want to give to this person writing in?
We think that some of the newer drugs might be better for lung GVHD. We are in fact testing belumosudil as a primary therapy rather than waiting for patients to get second or third line. But again, a lot would depend on what you've had and what your lungs actually look like. But there's no single answer to this question.
Okay, thank you. And this one, we're going to mix it up. I'm going to ask each of you your thoughts on this one. And I'll start with our social worker here. Are there any recommendations for the patient or the social worker on forgetfulness, brain fog? Sometimes it feels like I've developed ADHD after my transplant. Daniel, any thoughts?
Yeah, that's a great question. One that I've been posed a lot to. I always lead with, first and foremost, consulting with your medical team. Talk to your providers about that. Beyond that, I'm a big proponent of writing things down. Having sticky notes in your phone, lists or sticky notes, physical notes, and maybe in your house or in your nightstands and things like that, sort of subtle reminders and those sorts of things. We have so many different thoughts in our mind. We have so much stimuli coming at us all the time. Even on a good day, it can be hard to remember everything that we need to do. So sort of, our morning checklist, our afternoon checklist, questions that we want to ask the doctor. I'm just such a huge proponent of really writing things down and sort of coming up with our go-to, lists, so to speak, I think can become incredibly helpful. And if you have somebody, a roommate, a loved one, a caregiver, somebody in your support system that you have as an accountability partner as well, that you can review this list and these sorts of things with that person, because obviously we're talking about forgetfulness. We might forget about our lists. If you can review this sort of mechanism that you're creating with that person, then it can be kind of a check and balance with them too, so that they also know about, the questions you want to ask, where you have your list and things like that, to kind of have that additional accountability piece.
Great, thank you. How about you, Judy? Any thoughts?
Well, yes, and I will say it's another question that over my career is a very common question, and many friends ask me. And there's so many different things that can lead to what we call brain fog. And I would say, obviously, even having anemia or low blood counts, problems with the thyroid, people who have sleep apnea, we know when we treat that, things improve. And a lot of the medications that we take, medicines for anxiety and depression and chemotherapy. And so I think like the most important things are, which I try to do myself, try to get a good night's sleep. I eat a very healthy diet, many small meals a day, exercising every day, even 20 or 30 minutes, stress reduction. I mean, really being stressed and multitasking is, can be overwhelming, and avoiding excessive caffeine and alcohol. And the last thing I'll just say is it's kind of like if you don't use it, you lose it, in the sense that for so many of us, and I know myself, I spent days or weeks or months in bed and not doing much. And once I started to almost do some brain exercises, puzzles, I took some chess lessons online, I started reading again, I felt like that fog lifted to some degree.
Great advice. Thank you so much. And Dr. Cutler, any thoughts?
I mean, I think you've heard it from the pros from both ends. I don't think I have a lot else to add. Making sure that medicines aren't involved, minimizing medication lists, I think could be part of it as well. But yeah, I like the standard approach that you heard regarding really setting up reminders and systems to keep yourself in check over the course of the day.
Great, thank you. And here's another one for you, Dr. Cutler. Do you think ECP and Resurrect is a good combination to combat lung GVHD? If it's working, when should a patient come off of ECP? Or if it's working fine, do you continue? And I have been on ECP and Resurrect for 2 years. I am stable. Is it good to continue on the regimen?
Well, any regimen that works is a good regimen. There's nothing magical about the combinations that we know about yet, so there's no combinations that we think are better than the other. And regarding weaning or stopping, that's really a question that I can't answer because I would need to see lung function tests and really understand how limited you are, and it's a risk-benefit ratio.
Okay, thank you. Another question here. Someone asks about, does the brain fog or forgetfulness ever go away? But I'm also going to expand that question and say GVHD symptoms in general. Is there any hope that at some point it might fizzle out for people? And I'll send that one to you, Dr. Cutler.
Well, I mean, I don't know that brain fog is necessarily GVHD per se. There's lots of things that can actually go into brain fog, and whether this is an effective chemotherapy or radiation or other medicines that the patient who's asking is on. So I'm not sure that we can necessarily link brain fog and forgetfulness to GVHD. Does GVHD go away? The active inflammation almost always does, but if you've had it for a long time, you're almost always left with some of the long-term consequences of having had GVHD.
Okay, thank you so much, Doctor. Daniel, I'm going to send this one to you. As far as people who might feel stuck in that phase of grief as they're trying to adapt to the new normal, if someone's really stuck there, what would be some of your best advice to trying to get out of that?
Yeah, that's a great question. Feeling stuck is maybe, I don't know, the hardest or worst thing. The best thing to do is the hardest thing to do at the same time is to really reach out for help. If someone hasn't done so, is reaching out for help and having the courage to say, I need help. I'm struggling. I don't feel okay. I don't like the way I feel, and I need help. Because we all do at times. There are a tremendous amount of resources out there with peer support programs and counseling resources through, your social workers and your behavioral health teams at your various cancer centers and institutions, counseling resources in the community and things like that. But usually the hardest part is that first step of just being able to reach out and say, I'm not okay and I need help. And I just really want to validate that it is hard to do, but it's the most important thing to do, and it's okay to feel that way. It's okay to need help. Everybody does at some point in time in their life, but there are so many resources and mechanisms out there to provide support and to provide help. There are people that want to offer that help, and there are people that want to be involved in your life to help you feel better. So, whatever I can do to be encouraging and to be uplifting in that way, the best thing to do is just to take that first step and to, call your doctor or call your institution or, reach out to your loved ones and just say, I'm stuck and I need help, and what can I do? And then start working, with those people in your life to get connected to the resources out there, because they are there. But the first step is really just to say, I need help, and we'll go from there to find the supports that are available.
I appreciate you sharing that, Daniel. I also want to just kind of plant a seed here for people too. I think, as Daniel had shared, reaching out to your team. A lot of times your team will have referral or resources, and I think it's really important that people find people with an understanding of oncology when they're going through something like this, because not all counselors are trained in oncology-related issues. So, for example, if you're talking about the fatigue, they might not have the understanding that cancer fatigue is not something you take a nap from and feel better. And so making sure that you get referrals from your team or reaching out to Blood Cancer United, which is the Leukemia and Lymphoma Society, or BMT InfoNet, has a great directory that you can research for different providers or support groups. But make sure you reach out to your team and get some good referrals. I want to remind, we maybe could squeeze in another question if anyone wants to type one in, but I'm going to ask Judy this. Judy, if you were a part of the discharge team, having someone go home after a bone marrow transplant, and you could give them just any little advice on how to get through what the next stage is going to be, what would you tell them?
Oh boy. One thing that stands out to me is my transplant oncologist, Dr. Seufer. When I was feeling at my lowest lows, when I was fearful about having the transplant, I'm 66 now, so I was like 62 or something when I had the transplant. When I was fearful about what would happen after the transplant, I was afraid I wouldn't survive the transplant. He said to me, Judy, we have your back. And I have to say that those words, more than telling me exactly what to expect or what I should do, what I shouldn't do, because as we all know, we get this very big book. Dana-Farber gives you this big book with, everything to expect. Those words made me feel like there was a big hug around me all the time. And those words, and maybe if I didn't hear those words, I would have said to my caregivers, my clinicians, can I call you or reach out to you if I have questions? Because it made all the difference in the world. Being able to reach out, and I know Dr. Cutler and Daniel, have said that when, asked many questions. So the one thing I would say is if you don't hear that, just make sure you know how to reach your team, because I suspect that with all the worries, with new symptoms, with needs, they'll be able to answer your questions and direct you to the right person to help you.
Beautifully said, Judy. I so appreciate your words there, and I think that just like it was a big hug for you, people listening today, I'm sure, are feeling the same way with that comment. Thank you. I do not see any other questions at this time, so we are going to start wrapping up our program today. Again, I just want to thank everyone for joining us. I want to thank Sanofi and Johnson & Johnson for sponsoring the program. Of course, our regular partners, we appreciate everything you do to make these programs possible. Just so you know, there will be a survey coming out to everyone that participated today, and we ask if you could take the time to give us a little feedback, let us know what worked with the program, let us know if there's any other programs you want to hear about. But we thank you all for being here. We hope you learned some valuable tools or information to help you on your journey. And if there's anything we can do to support you, please reach out to us at MBMT Link. Thank you so much.
Thank you. That does conclude today's webcast. You may disconnect your line at this time and have a wonderful day. We thank you for your participation today.